This is a clinical briefing on the 2025 EMHG Guidelines for malignant hyperthermia. Our objective is straightforward: to equip you with the key updates for immediate application in your clinical practice.
Here's our agenda. We'll start with the key changes in the new guidelines. Then we'll cover the new MH genotype, or MHG. From there, we'll walk through the revised diagnostic pathways and clarify the ongoing role of the in vitro contracture test. We'll finish with the final clinical recommendations you need to be aware of.
Okay, let's jump right in. Section 1, Guideline Updates and Key Changes. What's actually different from the last version? Well, the biggest change is a fundamental shift in our diagnostic approach. We're moving away from a model that relied almost entirely on the in vitro contracture test, the IVHCT. We now have a dual framework that formally integrates molecular genetic testing and, importantly, establishes a new diagnostic designation.
And this is a big deal. For the first time, the guidelines provide a consensus definition of a clinical MH event. Now, the critical takeaway here is that the definition exclusively links a clinical reaction to anesthetic trigger agents. Why does that matter? Because it establishes a standardized, clear-cut phenotype, which is absolutely crucial for accurately assessing the pathogenicity of any genetic variants we find.
That leads us directly into Section 2, the new MH genotype, or MHG. This is that new diagnostic category I just mentioned. So what exactly is it? The MHG classification is assigned to individuals who carry a pathogenic or likely pathogenic variant, but, and this is the key part, have not undergone an IVCT. This creates a really important distinction. It cleanly separates a diagnosis confirmed by the contracture test, that's our classic MHS, from one confirmed by genetic analysis alone, which we now call MHG. And make no mistake, the basis for this classification is incredibly rigorous. MHG is defined by specific variants in the RYR1 and CACNA1S genes. Pathogenicity is determined by the EMHG's own very strict scoring matrix, which is a modified version of the standard ACM gene model. As of this publication, 72 RYR1 variants meet this high standard. For your clinical practice, just remember, the EMHG website is the only definitive up-to-date source for this list. Okay, let's get to the most practical component of this update, Section 3, the revised diagnostic pathways. This is where the new guidelines translate directly into clinical decision-making. Let's trace this first algorithm. This is for a patient with a personal or family history of suspected MH. You can see the pathway begins with a choice: go straight to IVCT or start with genetic testing. Let's follow that genetics first route. If you find a pathogenic or likely pathogenic variant, you have your diagnosis, MHG. That patient is considered high risk. But, and this is critical, if the genetic test comes back negative or you get a variant of unknown significance, you're not done. The algorithm mandates that you must proceed to IVCT. Only a negative IVCT result, an MHN, can definitively rule out susceptibility. Now, contrast that with the second algorithm for an incidental genetic finding. Here, if a pathogenic or likely pathogenic variant is identified, the result is the same, an MHG classification. The key difference is how you handle a variant of unknown significance. In this scenario, proceeding to IVCT is an individualized clinical decision, not a mandate. However, and this is a big however, a negative IVCT is still the only way to formally classify that patient as MHN and not at risk. These two pathways clearly delineate the distinct entry points into the diagnostic process. This brings us to a crucial point of clarification in Section 4, the continued and frankly non-negotiable role of the in vitro contracture test. So if there's one message to take away about testing, it's this. Genetic testing is great for confirming risk, but it absolutely cannot exclude it. Why? Because of allelic and locus heterogeneity. We know other genes or mutations could be causative. A negative genetic screen is simply insufficient. Only a negative IVCT can definitively classify a patient as MH-NIGAN. It remains the gold standard for exclusion. Now for practical application. Here are the key parameters for patient referral for IVCT. Note the pediatric limits, a minimum of 10 years and a minimum weight of 30 kilograms. And this is absolutely critical. For the biopsy procedure itself, the use of any MH-triggering agents is completely contraindicated. Furthermore, local anesthetic must not be infiltrated directly into the muscle tissue that's being sampled. All right, let's bring this all together in our final section, which synthesizes these diagnostic findings into unequivocal directives for perioperative management. The clinical takeaway here is unambiguous. Patients with any MHS classification, from an IVCT or an MHG classification, from genetic testing, are at increased risk.
For these individuals, you must avoid all MH-triggering drugs. Conversely, a patient classified as MHN by IVCT is not at risk and can be safely exposed to triggering agents. It's that clear. There is no middle ground.
So to conclude, these 2025 guidelines represent a significant evolution in our approach to MH. They formalize the role of genetics with the new EMHG designation while reinforcing the indispensable value of IVCT for definitive exclusion. This leaves us with a final practical question to take back to our institutions. Is your preoperative screening process aligned with these new integrated genetic and IVCT referral criteria?